who will be talking about the anatomy, a trip down the teary tract by Dr. Soumya Narayanan. Dr. Soumya is a consultant oculoplastic surgeon at Chandrakant Netralaya and Puttalat Eye Hospital, Kozhikode. Over to you, Soumya.
Good morning. A warm welcome to our IC on dacryology. My topic is a trip down the teary tract. So the lacrimal apparatus has a secretory part and an excretory part. The secretory part is mainly by the lacrimal gland, which has a larger orbital part and a smaller palpable part, which is divided by the levator lateral horn. You can see here the lacrimal ducts are passing from the orbital lobe to the palpable lobe. So if you are doing for a biopsy, it's better to take from the orbital lobe to decrease the damage to the lacrimal ducts. There are accessory lacrimal glands, glands of Cruz in the superior fornix and glands of Wolfram in the tarsus. And this will also secrete the watery component. There are meibomian glands and conjunctival goblet cells secreting the other components of the tears, and the lacrimal lake is formed. So about the drainage, it starts with the punctum. The punctum is seen in the elevation in the lacrimal papilla. It is 0.2 to 0.3 millimeter in size, posteriorly directed, and the inferior punctum is 0.5 to 1 millimeter lateral than the upper punctum. So in young patients, the size of the punctum, the shape of the punctum will be rounder or oval. With aging, there will be relaxation of the tissues and muscles around the punctum, and the shape will change to slit-like or fish mouth, later forming to a pinpoint stenotic punctum. So this is the canaliculae. We have a vertical 2 millimeter part and a horizontal 8 millimeter part, with the transition is seen by the ambula, that's the dilated portion. And you can see the surrounding structures to the canaliculae. The important one is here the puncti and the vertical portion of the canaliculae is surrounded by the superior muscles of Riolan, and the lateral 4/5 of the canaliculae is surrounded by the Horner's muscle. The importance we will talk later. The common canalicus is a 2 millimeter structure. The common internal ostium is drained to the sinus of Meyer, that is the laterally bulged portion of the sac. It is opened by the temporal traction of the Horner's muscle, and there is a mucosal fold known as the valve of Rosenmuller at that position. So lacrimal sac is divided by the medial canthal tendon to fundus, that is a 3 to 5 millimeter structure, and a body of 10 millimeter. You can see the posterior and anterior limbs of the medial canthal tendon attaching to the posterior lacrimal crest and anterior lacrimal crest. And here in this picture, you can see the lacrimal sac and the NLD and the bones around the structures. So the lacrimal fossa is formed by the frontal process of maxilla and the lacrimal bone, and there is a suture in between where we will start the DCR. And the black star is denoting the sutura nota. That is not a suture, but it's a vessel groove. The nasolacrimal duct has a 12 millimeter introitious part and a 5 millimeter meatal part, and the bone in nasolacrimal duct is formed supranasally by the lacrimal bone, infranasally by the inferior turbinate bone, temporally by the maxillary bone. The superior opening is about 6 millimeter in diameter, and there is also a valve known as the Hasnes valve. And this is the histology. In the punctum, canaliculae is formed by the stratified squamous epithelium, and there we can see a transition from the squamous to columnar. The sac is lined by the stratified columnar epithelium with few globular cells. So there are, other than valve of Rosenmuller and Heisner, there are other named valves also in the system. The valve of Bochdalek and folds in the punctum, and other valves in the sac and NLD. So our anatomy of the lacrimal system won't be completed without a nasal anatomy. We can see the lacrimal sac is corresponding to the medial turbinate, and the NLD is draining into the inferior meatus. So now about lacrimal drainage. There is a concept called crebial flow. A lacrimal fluid aspiration from the lacus lacrimalis into the punctum continues for a considerable period during eye opening. The aspiration from the punctum relies on the phenomenon of capillary phenomenon and a negative pressure in the canalicular lumen. And there is a pressure gradient from canaliculus to the sac, and we can see how the negative pressure is formed. So I have already told the lateral 4/5 of the canalicula is surrounded by the honus muscle. So during eye closure, the honus muscle will contract, and this is contract the canaliculus also. So the tear will drain into the medial 1/5. That is pulled down by the honus muscle here. So the tear is drained into that portion. And there is also honus muscle moves postero-nasally here. So that will start from temporal to medial. So it will squeezes out the canaliculus and drain into the sac. So the reverse happen when eye opening. The honus muscle relaxes along with the relaxation of the lateral 4/5 of the canaliculus and compression of the medial 1/5, and that tears drain to the the tears is pooling in the temporal 4/5 of the canaliculi. And when the eye is closing, honus muscle relaxes and the sac closes, and when the eye is open, honus muscle contract and the sac opens. So this is a neurovascular structures around the lacrimal apparatus. We can see the supratrochlear nerve here, infratrochlear nerve, and infraorbital nerve, and the external branch of the anterior ethmoidal nerve. These are very important during our DCR and DCT surgeries to give the local anesthesia. And we can also see angular vein here, which is formed by the supratrochlear and supraorbital veins, and this is seen usually between the 4 to 8 millimeter from the medial canthus, and this is also an important landmark during our DCR and DCT surgery. You can also see the medial palpebral artery in that region from the angular vein. Thank you.
Thank you so much, Soumya, for setting up the way for the rest of